Good morning, everyone. We are going to get started because we're at 6:32 and we do have a bunch of folks online. So we're going to get going because we have two fantastic presentations and I want to make sure we have time for them both. So welcome to Grand Rounds. It's pretty awesome to be here in person. We did a one-time shot before Delta hit us, but this is like the first time we've really been here in person in 2 years. And so it's wonderful to see everyone here. And thank you for everyone who's joining us online. One quick reminder for after this, make sure you all do remember to join the faculty resident review that's happening from 7:30 to 8:30 this morning online to follow Grand Rounds. So this morning we have Dr. Ray Yeung, who is a long-term professor, the originator of our liver tumor clinic and so many other things here at the University of Washington, and really kind of the lead for looking for genetic ways to help and really minimally invasive management of liver tumors. And also we have Dr. Scott Brakenridge, also not a unfamiliar face. He was with us for fellowship, both in trauma critical care and vascular surgery after residency, briefly, well, somewhat briefly. It was at the University of Florida, and we are happy to have it back. So I'm going to keep it very brief because I want to make sure we have lots of time for these fantastic presentations for one of our research Grand Rounds.
Thank you very much. Good morning. This is very refreshing. I can't remember the last time. And like Doug was saying, it looks totally different. It's a classroom now. Anyways, thank you for the invitation. I'm sort of representing the Surgical Oncology Lab today to give you a brief advanced research report focusing on a relatively new area that we dove into in cancer sensitivity testing. You may say, well, don't we have enough of these already? And the short answer is yes and no. You've probably heard there are lots of different ways of monitoring how cancer behaves to certain drugs. But you have to ask yourself, how many clinically relevant tests are out there? I guess we're not medical oncologists, so we don't directly order these, but do you know of anyone currently that is ordering patient-specific cancer sensitivity tests? There are a few companies out there, but not many. So I think there is still an actual gap in this area. So what I'd like to do today is quickly review some of the current methods that are available for drug testing, and then dive into an area that we were interested in about 5-6 years ago in conjunction with my colleagues, Dr. Claricetti and Dr. Chris in pathology, where we redevelop, if you will, reinvent the tumor slice culture platform. And then as a derivative of that, we modified it to develop a clinically relevant assay. So I'll go through some of those steps with you today. You may ask, well, what's the problem? How do we frame this? Well, as a surgical oncologist, we deal with patients with colorectal liver metastasis literally on a daily basis. Unfortunately, it's becoming more and more common, especially in folks under the age of 50. I think the majority of my practice is now in people less than age 50, which is scary, really. But that's off topic for today. The question is, in choosing their chemotherapy, right now the medical oncologists open up their NCCN guidelines and they see 3 options, as you see there. The first 2 are doublets. They include 5-FU oxaliplatin or 5-FU irinotecan. And then more recently, there's data to support, just throw the whole kitchen sink at them. So FOLFOXIRI. In addition to one of those targeted agents, either anti-VEGF receptor or anti-EGFR. So you can imagine that even with those options up there, you have at least 6 different combinations that you can offer the patient. Question is, which regimen is most appropriate. You may say, well, since they're active compounds, just throw everything at them. Yes, indeed. Actually, with FOLFOX3 plus Avastin, for example, you can get a response rate probably in the range of 70% or higher, which is very good. But what if you know a priori that, oh, that particular cancer actually does not respond to oxaliplatin combination? So you're subjecting that patient to unnecessary toxicities without any gain. So it's a balance. So in order to do the testing, we need models. And most of you know there are many different ways of dissecting human cancers. The most traditional and method is shown over there as a two-dimensional cell culture, where you can grow them on plastics. But we know over the years that that really does not resemble the human cancer very closely. In fact, the more closely the model is to the actual tumor in terms of its composition, in terms of the architecture, to resemble the tumor microenvironment, the better the model. So in recent years, people have developed three-dimensional cultures in the form of primary spheroids, as you see there, or organoids. They're slightly different. I'm not going to get into it today. And yet other people have injected the tumors directly into the flanks of severely immunodeficient mice, so-called patient-derived xenograft, PDX mice. And there are multiple companies out there that are doing that right now. And then finally, what I'm going to focus on today is organotypic culture, where we just take the tumor in its original form, slice them up, and put them in culture. This is exactly what that tumor represents. So a quick comparison. Over on this side, the features that I was talking about in terms of recreating that tumor microenvironment, right? You not only have tumor cells, you have stromal cells, you have immune cells, and you also have the extracellular matrix. Obviously, if you have a cell line, you only are focusing on tumor cells, and you derive at that through a series of passaging in culture representing a selection process. So you basically eliminate any kind of heterogeneity over time, but it is renewable. On the other hand, primary organoids can incorporate some of the other cell components, such as even immune cells. However, the current system that is available seems to suggest that those non-tumor cell components are short-lived. They can live for a couple of passages and then they eventually disappear. So they too undergo selection over time. The PDX is probably, you could say, well, is the in vivo model that truly resembles the tumor because it actually grows as a tumor, right? Yes and no, because a lot of these stromal components that we see are actually from the host, which is the mouse, not the human. And of course, these mice are severely immunodeficient, so the immune component is very much disrupted. Although of late, people have reintroduced the human immune cells back into these mice, okay, through almost like a marrow transplant into these mice, so they can actually express them. But you can imagine how costly those animals are, just each animal. And then finally, in terms of what I call TSC, which is a tumor slice culture, obviously we recapitulate the entire human tumor microenvironment. But the big problem is it is not renewable. So if you want to do your experiment over and over and over and over in the same sample, that cannot happen, okay? Because it does not go through any kind of selection. you say, well, how long can they live for then? Well, they can actually survive for weeks, if not months, but you just can't reproduce that slice for a different set of experiments. The actual, from the clinical assay development standpoint, the most important factors are actually outlined there. Is the take rate, or how efficiently can you produce that model from individual tumors, and how long does it take for that to happen? Obviously, it's important if I take a sample from a patient that I want to formulate a therapeutic plan, I cannot wait months to do that. But that's exactly what is required for some of these, in particular, the PDX mice. First of all, in that situation, the take rate is relatively low, depending on the tumor type. For colorectal cancer, it's not bad, but for something like primary liver cancer, hepatocellular carcinoma is very low, probably in the range of 15–20%. And it would take months. We were interested in a different type of liver cancer, and we had put about 6 of them into these mice over the years. And our tick rate was 0%. None of them took. And we kept the mice going for a year to see if there's any evidence of growth. So you can imagine the cost is enormous. So in terms of a clinical assay, obviously you want every one of those to take to create a model where you can test. You want to turn around time to be as short as possible, days, not weeks or months, to make it clinically relevant. And then of course, there's cost consideration as well. So let's dive in a little bit more about the organotypic culture. It is not a new way of growing human tissue. In fact, this has been used for over 75 years. The first publication of a mouse organotypic brain slice was published in 1947. It was to study neurophysiology. Subsequently, people have used it to study toxicology and a lot of different things, including cancer, more recently. So I just select one publication that came out in 2015 using this slice culture platform to predict therapeutic response in human cancer. And this was a landmark paper because they actually developed a machine learning driven algorithm to come up with a score to predict sensitivity. And as you can see in their test cohort of over 50 patients, the extreme performed really well. In particular, those that were predicted as, this thing doesn't work very well. Where are you? Non-responder, none of them actually responded. So that's excellent. So maybe it's too good to be true, actually. Right? And they went on to show that it actually predicts better than our current biomarker in colorectal cancer. For example, the use of an anti-EGF receptor, like cetuximab, based on the RAS status. Their algorithm performed better than that. They actually developed a company and went through several clinical studies. But as far as I can tell, so this was in 2015, 7 years ago, as of last year, the company disappeared. I don't know what happened to it. It just disappeared. So something went awry there. Maybe it's just too good to be true. So we went back and developed this platform here, not so much to focus on drug testing per se, but was really to look at some of the mechanisms downstream of some of these therapies that we're looking at. In my lab, we're focusing on the effects of chemotherapy on the microenvironment. And in Dr. Clarisetti's lab, he was obviously focusing on the immune microenvironment right from the start. But over the years, we have created a fairly robust protocol to do this. For any of those of you who are interested, it was recently published, and it goes through step by step. You can't go wrong with that. This work was spearheaded by Heidi Kernison, who's the senior research scientist in the lab. You also recognize some of our past and present residents were an integral component of this. So essentially what we do is we take the tumor that we cut out in the operating room and use the punch biopsy. There's a 6mm punch there. We create these cores, and then we use the vibrotome here to slice them up. So they're very, very precise in terms of their dimensions. So they're 6mm in diameter, and we cut them to 250 microns thick. So once you put them in culture, you can treat them with anything you like, whether it's a drug, an antibody, cells, and then there's a whole spectrum of endpoints that you can examine. And all of these we have used successfully from the slice. So as I was saying, we're interested in the effects of chemotherapy on the colorectal liver metastasis. And then as an aside, we did about a dozen of these. And it turns out that our in vitro response correlated very closely with the ex vivo, with the patient's response in clinic. So we're excited about that. And that's where we got the idea, maybe we could just use this to determine response. It's quite simple, right? You just take the tumor, slice them up, culture them, treat them, and within a week, you have an answer. But when you think about it, it doesn't quite work, because in order to do this, you have to have a chunk of tumor. Where do I get that? Well, that will limit them to patients in whom we're taking out the tumor, right? So that's the main limitations here. But the reason why it works is because we're able to standardize, and that's the key. We standardize the slice so that we can compare different slices, right? But in order to accommodate for the clinical utility, we have to change. We're to go to needle biopsy, right? This, I think everyone accept, oh yeah, this is just a clinical test. You go in, you get a core biopsy, and off we go. So the first question is, well, do these things actually survive in culture? And the short answer is yes, they do. Here I show you two examples. It's 16 gauge, slightly larger compared to 18 gauge. And they survive. And we just took this at 4 days. But the problem is, how do you standardize that, right? So many of you have done biopsies and you realize every core you take out is different. They're different lengths, they get fragmented, the integrity of it is different. So it is extremely difficult to standardize based on that, right? But we like the idea of measuring it, the metabolic state of the tumor, which is our current standard way of gauging viability. So this is very similar to a clinical test that we all know, which is a PET scan. Not any PET, but an FDG PET, right? Oncologists orders this all the time. Before treatment, after treatment, you look at the change in the uptake of FDG. What is FDG? FDG is just a derivative of glucose, which is reflective of the glycolytic process in the tumor. When you treat it with an effective drug, you would expect the glycolytic rate to go down, all right? So the question we have was, can we find a way to measure these metabolic activities on a individual cell basis? That will standardize everything for us. So by chance and through luck, I found a investigator in the Seattle area who has developed exactly what we were looking for. This is Dr. Wei. He works at the Institute of Systems Biology. And a few years back, he created what's called on-chip metabolic cytometry. Fancy name. The whole purpose is to phenotype the metabolic activities of individual single cells. How do we do that? Well, we take the sample and we treat them like before, except afterwards we process them by disassociating them into single cells, all right? And then separating them, getting rid of the leukocytes from the non-leukocyte component of the tumor, and then treat them, not labeling them, with metabolic compounds. One is just the same as the FDG, a slightly different derivative called NBDG. It's also a glucose derivative. It does the same thing. When it gets into the cell, it gets added a phosphate group at the C6 position by hexokinase, and then stays in the cell. The only difference is, upon doing that, it shows up as green. It's a fluorescent compound. Same with the mitochondrial side. We were using MTS assay I showed you before, which utilizes a tetrasodium salt that gets reduced by the oxidative phosphorylation to change color. Here, the only difference is this compound changes into a fluorescent compound upon reduction, and it turns blue. So as you can see, with that single cell, we can then sort them, measure the luminescence of these things. So here's an example. We took a sample and treated them. This is a cholangiocarcinoma, and then analyzed the degree of glucose uptake, as well as the oxidative phosphorylation. And then we do a ratio. So remember what I said, if a tumor were to respond, you would see a shift, a downshift of glycolysis compared to oxidative phosphorylation. And we express it as the N to R ratio. So here you can see after treatment with FOLFOX, we see a reduction in that ratio, suggestive of sensitivity. And we compare it to our standard slice culture assay, and they match. We've done this over and over, and they seem to correlate very well. So it looks like the OMC assay is a reasonable readout that no longer relies on the size, right? This is on a per cell basis. And furthermore, we have taken needle cores and compared to the slice, and essentially we're seeing the same thing. At least in this case, it's a preclinical tumor model that we're using. So that's where we're at. What we are trying to do now is to get a whole bunch of human samples where we can compare side by side our traditional slice with the needle to see if they correlate. Assuming that does happen, this is the end product. So by combining two platforms, the organotypic culture and the OMC, we have created a new assay, which we call MetaboCore, which utilizes clinical core biopsies to determine relative drug sensitivities of 2 or 3 different regimens, hoping that that is the current, to fill in the current gap in terms of asking which of these work. This is not an assay for discovery. If you've gone through all the drugs, say, well, what else can I use? I don't know. Well, let's go and screen 10,000 compounds. This is not going to do that for you, okay? Because it's not renewable. We can't duplicate these over and over and over. However, we have determined that the turnaround time is very short. We can get you the answer within a week. And as far as we can tell, it's relatively cheap overall. where do we go from there? We still have to do a bunch of optimization and standardization in order to make this a clinical grade assay. But hopefully we will know in the next year or two as we try to move this into clinical space. So as I said, the work was done by Heidi Kernison in conjunction with a talented postdoc in Tang under the guidance of Dr. Wei. We're fortunate to have the support from the DoD funding. I also want to acknowledge the Fred Hutch for supporting our biosuppository infrastructure from which we get these de-identified human tissues from. Last but not least, Surgical Oncology Lab. It's not just me, there's most of my colleagues who are interested in some form of oncology research. And I'm most proud to say that all of them, at least currently, are independently and externally funded for their projects. So I hope that you will all get to hear their progress over time. Thank you for your attention.
All right, thank you. It's an honor to be able to talk here and give it a little bit of time to share what we're doing in person. I don't think I realized until now when I walked up this morning about how much I missed the chance to meet on a weekly basis and come and talk to people you don't see every day. And until I realized that I've been here 8 months and hadn't even had a chance to talk to Dr. Marquardt until we were standing out front and having a cup of coffee. So I'm really glad to see that hopefully we're all gonna do this a little bit more often. All right, so I'm gonna give kind of a crash course here. I'm probably about 40 years of background of science and put it into about a 20-minute pitch, but hopefully it's gonna lead to a nice cogent story about where our research is currently heading on this journey from the genomic storm to a precision medicine future. A couple of disclosures: the Inflammation and Host Response to Injury Program and the Sepsis and Critical Illness Research Center at the University of Florida, as well as the Trauma Genomic and Metric Development Studies I'm going to talk about, were funded exclusively by the NIH. And I have a research, or have had a research contract with Informatics Incorporated, which is developing genomic diagnostic technology through an industry academic collaboration through BARDA from the Health and Human Services, and been co-authoring some publications with them. Okay, so the objectives of this talk is to understand how hemorrhagic and septic shock induces a genomic storm within the innate immune system, to gain an understanding of the pathobiology of persistent inflammation, immunosuppression, and catabolism, we call PICS syndrome, that is the pathophysiology that drives chronic critical illness after shock, be able to delineate the roles and limitations of biomarker-driven prognostication and prediction in critically ill surgical patients, and understand the concept of disease endotypes and their role in future precision medicine approaches. And I think this is going to be extremely complementary to Dr. Yeung's recent talk, whether or not it's just dumb luck on my part or excellent strategy by the department. I think it's going to be very complementary to what you just heard. So my provocative question of the day for you is: survival to ICU, getting out of the ICU, a victory? Should we be slapping each other, giving each other high fives, as the recent champions have been able to do? It's a tough question nowadays. So inpatient mortality after critical illness and shock has progressively declined over the past 30 years. Inpatient mortality after sepsis has dropped from nearly 50% to probably less than 20 to close to 15% now. And severe trauma patients who don't have devastating TBI, mortality has dropped from 25% to less than 10% over, say, the past 20 to 30 years. But does survival to the ICU equal success? And I think that's the question, because we think about survival and getting out of the ICU as black and white, dead or alive, but it's not. Survival after critical illness is this gray. It's this very oblique, kind of opaque spectrum. So to kind of understand this, we have to talk about how multiple organ failure has evolved over the past, really the course of my entire lifetime. So and it's really how the clinical phenotype of MOF has multiple organ failure has changed over the last 50 years due to tremendous advances in knowledges and care in surgical science and trauma science. And so back before around the time of the coming out of the Vietnam conflict, if you developed multiple or organ dysfunction after shock, you were dead, period. Now, that started to change in the 1970s as modern surgical ICUs were starting to be developed, as we could give organ support with ventilators, dialysis, pulmonary artery catheters, if anybody knows what those are anymore, TPN. And as the years progressed through tremendous advances, both in knowledge and in clinical care, the phenotype has changed. So after we were able to support people with organ dysfunction and shock, then there was started to emerge septic multiple organ failure, where people would have secondary insults with infection and develop more organ failure from that. Things like CT guided diagnosis and interventions like drainage, the robust development of trauma systems, damage control surgery, and a modern surgical critical care basically allowed us to support patients and resuscitate them and get them through it. But then we would have, people remember back around the turn of the century, as I was starting residency back around 2000, we had this epidemic of ICUs filled with patients who were blown up like the Pillsbury Doughboy from crystaloids, from overloading people with salt water, and on the ventilator with 4 chest tubes and just maxed out support. And then as we started to understand that over resuscitation in and of itself can be harmful, through and the development of more rapid hemorrhage control approaches and resuscitation with balanced blood product resuscitation, as well as the knowledge that we started to obtain, and especially the clinical standardization of best care through the Trauma Glue Grant program, which many people from this institution, I'm sure it's not anything that's new. It was a multi-institutional consortium funded by the NIH, 6 centers where looking at the epidemiology and also the biology of the genomic response to hemorrhagic shock. Improvements from there, we've basically gotten to the point now abdominal compartment syndrome has essentially disappeared. The Abdominal Compartment Syndrome Society is basically a ghost society nowadays. And early deaths from multiple organ failure have gone away. So are these patients shock survivors? We should be giving ourselves, should we be high-fiving like Kansas and South Carolina? Should we be celebrating this as a victory? Well, as I mentioned, the clinical phenotype of shock and multiple organ failure is changing. So as we mentioned, the advancements in organ support and implementation of evidence-based protocols has significantly decreased inpatient hospital mortality, but the clinical burden is shifting. So it's transitioning from early mortality from refractory shock and multiple organ failure to this kind of prolonged smoldering course of intensive care. And we call this chronic critical illness, which is greater than 14 days, 2 weeks of ICU length of stay with persistent but manageable organ dysfunction. People are laying in the ICU on ventilators or on dialysis. This is an acute muscle wasting condition where people are wasting away, very rapidly losing their muscle mass. They develop recurrent infections that keep them bouncing back from the floor back to the ICU with sepsis. They survive to discharge, but are sent to long-term acute care hospitals and skilled nursing facilities. And they have dismal long-term outcomes. I know every single one of you in this room have taken care of these patients. So more patients are surviving shock. The data on this is clear, and patient mortality is dropping, but the development of chronic critical illness is increasing rapidly. And again, it's just a shifting of the burden of disease. It's not that we likely have made a big impact on mortality, but we haven't gotten rid of the underlying pathophysiology of the disease. Even though more patients are surviving, they're languishing in the ICU with persistent organ dysfunction. And they get out of the ICU alive, but chronic critical illness, CCI patients linger and survive, but with severe disability. As you can see the comparing here, the difference between rapid recovery patients, those are patients who recover within 14 days and leave the ICU versus CCI patients who are stuck in the ICU for 14 days or more. Now, these are highly functional people walking around in our communities. But the patients who develop CCI, those that survive to discharge, have severe disabilities that are persistent now to at least 1 year. So at this point that we followed them. And a lot of the data here I'm going to be showing you is when I left the University of Washington, I was lucky to stumble upon an opportunity to go to the University of Florida. And that's really where I developed my team science career. I got there at a time when they were running a P50 grant for the Sepsis and Critical Illness Research Center, where I was able to be a co-investigator and lead 2 of the cores. And it was just a phenomenal experience. And that's where a lot of this data is going to be coming from. And these patients have dismal long-term outcomes. We followed 300 patients over the course of 5 years at the Sepsis and Critical Illness Research Center. And if you look at the difference between CCI patients, 30-day mortality, about 13% of these patients are alive at 30 days. But if you follow these patients out to 1 year, almost half of them are dead. If you get out of the ICU within 14 days, your mortality at 1 year is 5%. So is it a victory to get out of the ICU if you've been in the ICU for more than 2 weeks? So I'd say that data is pretty shocking, and at least enlightening to me. So what is the underlying mechanism of the poor outcomes in these surgical ICU quote unquote survivors? Why can we not, what is driving this? So this really has its basis in understanding that there's a genomic storm after shock. And this is what we began to understand through the Trauma Blue Grant program back in the early 2000s. So the Inflammation and Host Response to Injury program involved 6 level 1 trauma centers, of which University of Washington and Harborview were key players, investigators, Dr. O'Keefe, Dr. Fuscieri, and Dr. Mayer. And it enrolled 1,637 severely injured trauma patients. Again, they developed and implemented SOPs to standardize care across the centers, which in and of itself had a tremendous impact on outcomes, able to study in depth the epidemiology of shock, and importantly, to understand the underlying genomics of this as an inflammatory disease. And so what we came to understand is there's in severely injured trauma patients, hemorrhagic shock, there's a significant expression changes in over 80% of the circulating leukocyte genome. So out of the 20 some odd thousand genes that we have, there's 5,136 trauma responsive genes that had a change in expression more than twofold. And this, importantly, this fails to return by baseline. So if these are when there's these changes that you're seeing in the heat map over here, patients that are severely injured, there's a significant change in these genes. And importantly, the aberrancy in the transcription of these genes is persistent out to at least 28 days. And we know it's going to be beyond that as well, but that's as far as we've been able to look so far. So we also understand now that the genomic storm this is the underlying mechanisms that drive persistent organ dysfunction and complicating outcomes. So the classic dogma that you probably have seen in many surgical or trauma textbooks, or even with regards to sepsis, is there's this sequential SIRS and CARS response where it's this large systemic inflammatory response, then later transitions to compensatory anti-inflammatory response. And the Trauma Blue Grant actually helped us understand that that's not really mechanistic reality. There's a simultaneous pro and anti-inflammatory explosion of innate and adaptive immune dysregulation at the genomic level. Then there's a delayed and failed return to the genomic baseline in patients that have complicated outcomes. And the systemic inflammation and organ dysfunction fails to resolve and leaves the immune system persistently dysfunctional and patients susceptible to recurrent insults and complications such as infection. We also know that this genomic storm is conserved clearly across trauma, burn, and pretty closely with sepsis, and probably is applicable to all pro-inflammatory disease insults. You could see this being pancreatitis, et cetera. And there's a very strong correlation between the gene expression between these diseases. So this is kind of a unified innate immune response. And importantly, in chronic critical illness patients, we've been able to show that the genomic storm fails to resolve and is what is driving this underlying illness. So CCI patients have persistent inflammation when you look at systemic circulating biomarkers, IL-6, IL-8, or if you also look at markers of persistent catabolism, suppression of the IGF axis, or urinary catabolic markers. These patients have persistent inflammation. They're persistently in a catabolic state, which they can't resolve at least out till 28 days after their insult. Importantly, these patients are persistently immunosuppressed. There's elevated biomarkers of immunosuppression, such as soluble programmed death ligand 1. These patients are persistently lymphopenic with depressed ALC counts, and the cells they have aren't working. There's decreased MHC class 2 antigen presentation and decreased T cell adaptive immunity. And importantly, these mechanistic findings manifest themselves clinically. So these patients, there's acute and persistent phenotype of muscle wasting. This is some data from one of my T32 fellows at the University of Florida, where there's at least an 8 to 10% acute loss in muscle mass from their baseline, which is persistent still at 3 months when you've imaged these patients again at 3 months. And these patients have what I like to call sepsis recidivism. They keep bouncing back with recurrent infections. There's a 3-fold increase in secondary infections in people that develop CCI. And as I mentioned at the beginning of the talk, the mortality, especially after sepsis, is almost 40% at a year. And 60% of these deaths are from recurrent sepsis or non-resolving multiple organ failure, i.e. the genomic storm has not resolved. The underlying pathophysiology has not resolved. Okay, so this cartoon schematic here is how we like to kind of conceptualize what pig syndrome is, if you want to think about it in the similar context to that initial genome, the initial Blue Grant figure that I showed. So we have a pro-inflammatory insult such as sepsis or trauma, which triggers a genomic storm, an explosion in both pro and anti-inflammatory gene transcription and functional abnormalities. Some patients go on to develop early multiple organ failure, but those deaths, as I mentioned, have pretty much gone away. We can resuscitate the vast majority of those patients. Some of those patients, probably at least about half, thankfully, develop a rapid recovery, return to their hemostatic or to their genomic and immunologic homeostatic state, and they recover and get out of the ICU. But the remainder of that quarter to a half of patients smolder with persistent low-grade pro-inflammatory state and inflammation, have progressive immunosuppression, and these are the patients that develop chronic critical illness and have what we call, which is the PIC syndrome, which is persistent inflammation, progressive immunosuppression, and persistent catabolism, leading to muscle wasting, inability to rehabilitate, recurrent infections. What we hypothesize is the underlying biologic mechanism of this is key contributor, at least, is the expansion of persistent and immature myeloid lineage cells such as MDSCs, which some of you may be familiar about with in the realm of cancer. That is another probably multi-hour talk in and of itself, but that is what we hypothesize is probably the underlying biologic basis. So I like to kind of, this is kind of a obtuse kind of thing to try to conceptualize, but I just try to think about it. I'm a simple mind. I try to think about it very simply. So I think about it like a campfire. So in other words, our immune system, our immune homeostatic state should be a nice little crackling campfire. It gives you heat. You can cook a couple marshmallows over it, and it's doing what it's supposed to do. So an insult of trauma or sepsis is like throwing kerosene on the fire. Boom, there's a huge explosion, it burns the people around it, very destructive, dysfunctional. And then what you're left with is a bunch of smoldering coals that really aren't doing anything that you can't boil water over it. It's not really keeping you warm. There's sparks flying off it that are starting fires in the brush nearby. And so that's kind of the underlying biology, the inflammatory biology that we're left with in these patients that have PICs and chronic critical illness. So how does this relate clinically? So trauma and sepsis are diseases of the immune system. I think hopefully I've convinced you of that. And immunomodulatory drugs exist. So let's use them, right? Seems pretty straightforward and simple. Well, the wastelands of the sepsis wars of the 90s are littered with immunotherapy casualties. I'm sure many of you have seen many of these studies, approaches anti-TNF, trying to give targeted therapy in the setting of this huge genomic explosion just has not panned out. And why is that the case? We've learned so much about this underlying mechanisms. Why are there no immunotherapy silver bullets in sepsis and trauma? Well, there might be three possibilities. Maybe the first is maybe none of the drugs are effective. It's just we were just wrong. But they work in preclinical and early phase 1-2 trials. Maybe the underlying science is flawed and animal models don't replicate the complexity of human disease. And that's true. Research mice are inbred clones. Humans are not. Humans have a heterogeneous scope of and spectrum of responses. Or maybe the drugs are effective in animals may only be effective in some subpopulations of patients and not others. And number three, the important thing to remember is that clinical trial and outcome selection is incredibly important. And if you do not select an outcome that can detect or reflect the complexity of the disease, i.e. you're trying to improve short-term mortality where short-term mortality is, you've had such an improvement in short-term mortality that maybe there's no more room to budge there. You really can't, it makes it impossible to reach treatment goals in these trials. So one argument might be that the future of trauma and sepsis therapeutic trials is being able to prospectively identify the patients who both require intervention and are likely to benefit from a specific therapy. That's precision medicine. So is there a role for biomarkers in trauma and sepsis interventional trials? And I think it's important to understand the difference between prognostic biomarkers and predictive biomarkers. Prognostic biomarkers in most diseases, they're a dime a dozen. You can use clinical scores, you can use a circulating biomarker. The bottom line is it prognosticates a patient outcome. If I measure this at this time, how is this patient going to do? Okay, to identify a true predictive biomarker, that's a biomarker that actually predicts a patient's response to a targeted therapy, which is very different. And it's important to understand that distinction. So can the signature of the genomic storm serve as a prognostic and a predictive biomarker? And so kind of the child of Blue Grant, if you want to think about it that way, developed here and at Harborview, as well in collaboration with the University of Florida, where I was previously, From the genomic data from the Blue Grant, we were able to develop a 63 gene leukocyte transcriptomic trauma metric. We call it the S63 or the Sweet 63 gene set. When measured at 12 to 24 hours of injury in the initial discovery study, we showed that you can use the signature of these 63 genes to develop a difference from reference metric, genomic metric, which quantifies the overall aberrant transcription of these trauma responsive genes. And it is able to distinguish patients and prognosticate patients who will develop uncomplicated versus complicated outcomes. So this sounds pretty good. You know, it's better than some other circulating biomarkers or clinical scores, which can take you 24, 48 hours sometimes to get the data to calculate. But what's the turnaround time? And we're talking about genomics here. So if you think about it, I mean, basically, traditionally, and especially through the Glue Grant, I mean, all these analyses were done on microarray gene chips analysis, which take days to weeks. In the setting of sepsis or trauma and acute disease process, to use that as a diagnostic just doesn't really make any sense. You need a clinically relevant technical platform to translate this to clinical care. And so we're starting to take those first steps towards diagnostic genomics. One technology that we begin to implement are technologies such as fluorescent barcode molecular probe multiplexing, which is a clinical application ready platform that exists now. It's 510(k) cleared for clinical diagnostic use, which is important because you have to have that clearance to be able to use it as a diagnostic moving forward. And importantly, it can utilize any open source gene set or set of algorithms that you want put into it. And it takes about 24-hour turnaround time to get multiplex genomic results. It's been validated and is actively used in some indications such as like for the prostatic breast cancer prognostic signature assay. So using this technology, we went about trying to validate in a clinically relevant setting this trauma genomic metric. So we utilized this advances in genomic technology, and we developed using this platform an 18-hour turnaround laboratory developed test in our CLIA CAP lab at the University of Florida. And we collaborated by enrolling patients also here at Harborview. We did the analysis in Florida. And basically what we did was we were able to validate and use this as a validation cohort for the Sweet 63 trauma genomic metric. And it's found, again, confirmed and validated that this is highly prognostic for the development of chronic critical illness after trauma. So good from a prognostic standpoint and getting to the point where we can use it potentially clinically. So what about genomic diagnostics and sepsis? Sepsis is a very challenging, many of you know, especially in the ICU setting, because if you have uninfected patients in the ICU with organ dysfunction, they get a little worse, something's not right, are they infected or are they not? So being able to diagnose whether or not that this is related to infection is incredibly important. And this is the realm where industry has entered the game. And the interesting thing is that the gene sequences in these sets through federally funded research is all in the public domain, but the device technology and algorithms are what are proprietary, and that's what's driving the market for this. So one way that has definitely pushed this forward is collaboration between government funding, industry, and academic through initiations such as through BARDA from Health and Human Services, are advancing technologies very rapidly. We were at the University of Florida, we were collaborating with and doing research in conjunction with Informatics, who's been developing a diagnostic genomic metric for both diagnosis of infection and prognostication of outcome. And importantly, what's happening is the time frame for obtaining genomic results is rapidly condensing. It's very rapidly becoming down to point of care use. And within the next 3 to 6 months, I'm hoping that I will have a device here on campus that will be able to return a genomic signature within 15 to 30 minutes. So we've gone from days to weeks to potentially using this information within minutes. Okay, so prognostication is great. And so this patient isn't going to do well. But what about predicting response to therapy? That's really what's important for us to change the disease. And so to have effective precision medicine approaches, we really have to understand the concepts of disease endotypes and the difference between a phenotype and an endotype. So a phenotype is what you see in the patient. So the groups of patients defined by clinical signs and symptoms. This is what most commonly drives clinical management at the bedside. You go to the bedside, you're looking at the information, what the patient looks like, and the information that you have that drives your clinical management. But that does not necessarily relate or give insight into the underlying mechanisms of what's going on in an individual patient. Endotypes are what lie beneath. This is the pathophysiology that you cannot readily see, but need to understand. They're groups of patients that are defined by their underlying biologic mechanisms, and they reflect differences between individuals in their host response with the same clinical quote unquote disease. And importantly, this is what dictates the response to individual and mechanistically targeted therapies. i.e. if we can't identify endotypes and we're trying to treat everyone, maybe that's why we can't find a signal when we try to modulate the immune system. So are there endotypes in traumatic and septic shock? And the answer is, I think we understand that, yes, we are understanding that it's a heterogeneous disease and there are endotypes within these quote unquote uniform diseases. Recently, we finished up a prospective cohort study looking at 100 trauma patients with severe blunt injury and hemorrhagic shock. We looked at serial biomarkers assessing systemic inflammation and immunosuppression, and not only their initial magnitude measured at one time, but importantly, looking at the trajectory over time. And understanding that there are, at least three endotypes based on the magnitude and the trajectory of the response. Not only what the initial response is, but what the trajectory of is that response persist? Does it resolve over time? So there are endotypes within these patient populations. So along those lines, in addition to that, to supplement that, can we get deeper mechanistic insight into trauma and sepsis endotypes? And the answer is we're working towards that, utilizing technologies such as single-cell RNA-seq. We're trying to understand at the cell population and specific single-cell level differences in these transcriptomic profiles of what the immune system is doing. And when you sample patients, sepsis patients 21 days after initial injury, we understand that their expansions of myeloid-derived suppressor cells with immunosuppressive transcriptome profiles and persistent lymphopenia, again, with immunosuppressed transcriptome profiles within T cells. Okay, are there any other more practical? That's the problem. Single-cell RNA-seq is not practical at this time. Are there other more practical methodologies to assist in determining what individual shock patient's endotype may be? And this is something we're actively working on here. And we're part of I brought involvement in the SPIES consortium, which is a multi-institute NIH-funded consortium trying to develop this technology or translate this technology to clinical use. It's basically, ELISpot is single-cell ELISA, if you want to think about it that way. It's a practical, timely, and dynamic function of both innate and adaptive immunity. It assesses both, importantly, the individual cellular response, but also the function of individual cells that you're able to quantify. And this also importantly facilitates the rapid testing ex vivo of response to therapeutics. And importantly, also, this exists as a existing CLIA-CAP approved laboratory application and machine for tuberculosis and fungal infections. So it's a clinically translatable device. And what ELISpot does is it gives you a functional readout of the immunosuppressive endotype. And this is, kind of making lemonade out of, lemons. We had to kind of delve into the COVID research world the last, year to 2 years. And what we were able to show is that when you look at COVID patients using ELISpot, that COVID patients compared to healthy controls on the right, COVID on the left, the COVID patients, similar to sepsis, have severe and progressive adaptive immunosuppression. We're able to endotype these patients. But also importantly, we're able to show ex vivo rescue of function through stimulatory agents such as IL-7, proving that this has potential for use as therapeutic evaluation technology. Okay, so what's the future? So hopefully moving forward, we're going to work on translating trauma and sepsis genomic prognostic metrics to relevant POC platforms. We're going to validate integrated genomic metascores within these genomic metrics that can help us identify endotypes. Didn't show a whole lot of data on that, but that's what we're doing moving forward. And determine and validate the synergistic yield for combining a bunch of these approaches to provide comprehensive patient endotyping and implementation of precision medicine, randomized controlled trials in shock. I need to acknowledge a little bit of the past in my time at the University of Florida and the NIH-funded Sepsis and Critical Illness Research Center, where most of this data was generated. But I'm also looking forward to the future. And it's so great to be back. It's just so exciting to be able to work at Harborview again and collaborate with Grant to kind of, now that the R&T building isn't glowing anymore, to get the lab back up running and functional again. And working with our T32 fellows and our research staff. And it's especially exciting to be back and working clinically with my partners. And so it's great to be back, and I look forward to what the future holds. Thank you very much.
So we have just a few minutes. So perhaps we'll ask both from chat and from live if we have questions for our two speakers this morning. Oh, yeah. So Dr. Bird.
Good morning. Can you all hear me? Yes? Can you hear me okay?
Go ahead.
Yeah. I just want to make a comment. I thoroughly enjoyed both presentations. Obviously, I know more about the oncology than Dr. Brakenridge's presentation. I just want to point out to the faculty and residents, little bit about Ray Yeung and where he's come from for about 30 seconds. Ray started in the mid-1990s studying tuberous sclerosis, a rare disorder, but he established his lab and his credibility and then expanded that on to the diseases that he does treat, primary and secondary liver malignancies. He helped in a huge way to recruit the current faculty that he acknowledged and gave them a research startup laboratory experience from which they received fundings, and then brought in opportunities for all of our residents to be able to start to enter those labs. And then finally, you see the relationship with Dr. Wei Wei, where he's established a community of scientists and brings those in to address the real clinical questions that we see. So he's brought in what we do as surgeons, which is access to tissue. And I just want to celebrate Ray's career in a small fashion. It's just so impressive, and I really enjoyed your presentation.
David, thank you so much for your kind words. And thank you for reminding me how ancient I am.
I'm more ancient.
Dr. Shelley, I really enjoyed both your talks, and one of the common themes that I've been seeing in pop literature, so not scientific, so that's why I'm asking both of you as experts, is the role of hyperinsulinemia and progression of disease, whether it's progression of cancer or worse outcomes after COVID. So people who are insulin, have high insulin levels or pre-diabetic or diabetic, think have a worse phenotype or endotype. So where does that fit into your research from both of your perspectives? Like, is anybody looking at?
I think the short answer to that is there are multifactorial aspects, especially of underlying comorbidity. I didn't dive into that for our literature, but underlying comorbidity clearly is a confounder and a contributor to, and as well as age. I didn't delve into that too, but so obviously age and comorbidities are probably the two most likely things to clinical differentiators from who may or may not do poorly in our setting. So it is part of the puzzle for sure. And I think the insulin resistance is kind of probably mostly reflecting the underlying, the underlying comorbidity of that. So I think that it is, I'm sure it's definitely a piece of the puzzle, at least for understanding what comorbidities are probably, contributing to some of these issues.
Yeah, and from an oncology standpoint, you're focusing on metabolism. As with trauma, obviously, it's extraordinarily complex, right, in terms of cause and effect and negative and positive feedback and feed-forward loops. But definitely, we know that, for example, insulin is a growth factor, right? So not infrequently, we will see the effects of tumor growth as a result of that. But how we manage that directly for patients, besides just glycemic control, has been looked at a lot because insulin feeds into critical pathways like the AKT and mTOR pathways, but hasn't really materialized in terms of a global strategic approach.
And post-injury metabolomics and metabolic response is kind of Dr. O'Keefe's realm. Do you have any comment, Dr. O'Keefe? Or?
I don't right now, but I think one of the things that we're finding, and I think this relates to both some of the Ray's interest in the liver and illness, is that in critically ill patients we focus so much on chronic influence chronic disease. The one missing is the liver disease. I think we don't have a good way to appreciate sort of mild or moderate forms of liver disease that has on outpatient critical illness. And there's starting to be more work looking at the insulin-related pathways and responses in the liver. And those might be what are in part driving a lot of the chronic critical illness. Is this sort of moderate to mild to moderate liver disease that we don't have a really good way to appreciate or understand. And so I think that's I think there's this great sort of loop between what Dr. Brakenridge to chronic critical illness. And it's the way we have it.
I didn't pay him to say that.
So sadly, in the interest of time, because we are over 7:30 and we do have the resident review, I'll have to pause. I do have some other questions that we received on chat from Dr. Brent Olschlager and Teresa Kim, and I will forward those to our speakers. Thank you everyone for being here today, both either in person or virtually. And I would say, you know, part of the goal of research grand rounds, which we do 3 times a year, 2 speakers each time, is to really highlight the truly amazing work that our faculty are doing in this department, not only just to highlight it, but also to hopefully harbor and benefit faculty collaboration between projects, right? Maybe one person doesn't know what the other person's doing and how can we work together, but also for our residents to really see what's going on. What are you interested in and what could you get involved in that's happening right here under your nose in the department? So thank you so much, Dr. Yeung, Dr. Brakenridge, and we'll see each other next month, hopefully continuing in person.